Good morning, everybody. And as always, thank you so much for being with us today. As you're all joining in, we have just a brief few updates today, a little less than usual. I first want to say our Dr. Bowman from Occupational Health is off this week. He'll be back with us next week, but he did want me to relay to you that, as usual, Occupational Health, the infection numbers for COVID in our community has been very, very low in the single digits and continue to do very well. He's also going to provide us updates as Dr. Maggio is phasing out into a new role. Thank you so much to Dr. Maggio for providing weekly updates about vaccines, and we really appreciate everything you've done for us. Dr. Bowman will provide more updates on that as well for us next week. Dr. Pinsky is going to be giving us important updates on the variants.
Thanks, Errol, and good morning, everyone. A quick update on the SARS-CoV-2 variants. The variant numbers are relatively low, as is our positivity rate. We have identified a number and confirmed a number of additional B117 UK variants, but no additional South Africa 1351 or Brazil P1 1128.1 variants. A couple of additional Brazil P2s, and still a large number of California variants, as you are all aware. And just to show that epidemic curve for the 427 and 429 variant, we have seen, here's the spike from the beginning of the year, the decreasing number of cases over time, and then the increasing in these black hexagons, the increasing prevalence of the L452R mutation, which is associated with the California variant. And this is consistent with what folks are seeing throughout the rest of the state. So that's the variant update for this week. Happy to take any questions in the chat. Thank you.
Thanks so much, Dr. Pinsky. As always look forward to hearing those updates. Next, we'll move to Dr. Harmon.
Thanks, Errol. Good morning. Stanford has an amazing history of women scientists in space. And in honor of Women's History Month, I wanted to highlight this event. Today's event is Stanford Med Live, and it will be literally broadcast from outer space. Dean Lloyd Minor and Dr. David Relman from our Department of Medicine will speak with Dr. Kate Rubins on the International Space Station. She is a microbiologist and a Stanford alumna, and that will be at noon. However, if you note the footnote, the time may actually change due to space connectivity issues. And so again, looking forward to that event. Thanks, Errol.
Thank you so much. And as we introduce our new presenter, just want to mention next week we have Dr. Eran Segal. He will be presenting to us from Israel. And this will be moderated by Dr. Ami Bhatt. He'll be talking about modeling predicting COVID-19 dynamics. And then the week after that, we'll start our part 1 of 2-part series of long COVID. The first part being the pathophysiology, and the second part we'll be looking more into the clinical aspects as well as other aspects of pathophysiology of long COVID. With that being said, I'd like to now turn it over to Dr. Kevin Schulman. Dr. Schulman, as many of you already know him, has given some amazing grand rounds this past year, and particularly very helpful at setting up with our presenter today. And he kindly agreed to introduce our presenter today. So Dr. Schulman, thanks so much for everything and for introducing today.
Thanks, Errol. It's really a great pleasure for me to introduce Dr. Seth Klickman as our grand round speaker today. Seth is Senior Vice President and Chief Health Officer of Blue Shield of California. He's been in that role, I think he took over in March, so really good timing in terms of transitioning out here to California right in front of the pandemic. Before coming to Blue Shield, Seth was president of the Intermountain Medical Group, and before that, president of the University of North Carolina Healthcare Population Health Group. So has really had 20 years of increasing experience of trying to tackle the issues that we're all dealing with about integrating value into clinical care and organizing physicians and physician practices to best serve our patients. Seth was a graduate of the University of Pennsylvania School of Medicine, did his residency in emergency medicine, University of Chicago, and then actually joined Duke for both his MBA and for a fellowship at the Duke Clinical Research Institute. So it's really a great pleasure to introduce former trainee and great collaborator and friend, Seth Klickman.
Great. Thanks, Kevin. Thanks, Errol. Thanks, Dr. Harrington. Really great to be here today. It's a true honor to be with you all. And I've only been at Blue Shield for a short period of time, but I know the work that we've done with Stanford has been really meaningful to our organization. There's been some great work around hospital and ambulatory quality, some exciting work now around virtual consultations with specialists, and also data and analytic projects. And so I look forward to enhancing and strengthening that collaboration during my time at Blue Shield. I thought I would spend some time today really talking about my journey as a physician executive, and then really talking in more detail about what it's been like for the last year, because I showed up in the midst of the biggest health crisis any of us have really ever experienced. And you're probably wondering, how did a physician executive who spent all of his life in academic medicine and was clinically active wind up in a senior executive role at a health plan? And so wanted to talk more about that, and then particularly the work that we've been doing as a company around our COVID-19 response efforts, and give you an opportunity also to ask questions about the work that we've been doing and hear what's on your mind. Let's go to the next slide. Just wanted to share a little bit about me, as normal as anyone can be in the pandemic. I made it to the Oakland area a few months ago. It took a while to physically move during COVID from Salt Lake City, but the pictures on the left are actually my wife and I playing our two pianos. So we used to only have one, but discovered that being holed up in the house for long periods of time, we were fighting over the piano. And since we both work from home, also we were really making each other crazy playing the piano. So we bought a second piano, which is an upright electronic piano, which plays really well, and you can wear headphones, and both of us can play at the same time if we have to, and be happy. And then a couple months ago, we added a new puppy to our family, Presto, and surprisingly, he's taken well to the piano. He seems to be very, very interested. I don't know if we're going to get him to quite be a musician, but we certainly are trying. And then in terms of leisure activity, I was a collegiate golfer, so been playing a little bit of golf only on the weekends. And Presto, our dog, also tries to read the putts whenever I'm out on the practice green, but the problem is he usually chases and eats the ball before it gets to the hole. So he's not proving to be a very effective companion on the golf course. But playing golf has been a great way for me to get reacquainted and also meet new colleagues and peers in the midst of COVID, because it's outdoor activity and it's really one of the only and probably the safest things that I can do socially, being new to a state and new to a job. So next slide, please. And I wanted to just give a flavor for why I got interested in medicine in the first place. And I think it really highlights why I'm taking on the work that I'm doing now. So my love for medicine was acquired really from my dad, who's pictured on the bottom right. So he was an epidemiologist and a veterinarian, and really dedicated his whole career to understanding interactions between animals and people and how that affects human disease. So the set of graphics on the left, that little red dot is a small town in southern France called Plaisance-de-Touche, where I spent 2 years during my early childhood growing up, because my dad was doing epidemiologic investigation work in collaboration with the French government, and this is an article that he wrote, there was an outbreak of visceral larva migrans in the French countryside, fairly large, and he was actually called in to work with the French health authorities to try and understand what was going on. And I remember him telling me he was doing his outbreak investigation, and the outbreak was primarily in a cluster of young women in their 30s, and he followed them around watching their day-to-day activities. And what he discovered is one of the big activities was the husbands would tend to the farm and harvest the meat, the pork that they would make into sausage, and he would see them seasoning the sausage with herbes de Provence and continually tasting the raw ground sausage until they got the seasoning just right. So I'm not sure it required 2 doctorate degrees to figure out the source of that epidemic, but it was Toxocara canis that was from the herding dogs that was getting into the pigs, that was getting into the people. And so there was an intense educational intervention put in place. All the dogs got dewormed, and visceral larva migrans was eradicated from the French countryside. So got really excited about medicine and public health. And then he dedicated the later part of his career to using animals as sentinels for environmental health hazards. So it was hard enough being a teenager, but that's my German Shepherd that used to be my companion. And what he has on his back is a prototype for a radon detector that he carried around with him, because my dad was testing whether dogs could be good sentinels for radon exposure. And in that microscope, he's also looking at interstitial tissue from lungs to look for early warning signs for exposure to asbestos in companion animals, because the latency period from asbestos exposure to mesothelioma in adults can be 4 decades. So really looking at companion animals as a way to do early detection of exposure and then early monitoring of humans that may have been exposed. And then all of that work precipitated to a National Academy report, which is sort of the modern day canary in a coal mine book about how to use animals as environmental sentinels. So thought that was an interesting overview, and really got me passionate about using science and data to improve population-based health. Next slide, please. So I subsequently went to medical school, as Kevin mentioned. I was a med student at the University of Pennsylvania. I did my training in emergency medicine at the University of Chicago. Really wanted a broad-based training, but my true love and interest was around population health, healthcare policy. And unfortunately, I didn't get the training that I felt like I needed just in traditional medical school and residency training. So at the time, I was actually applying to MBA programs that had healthcare concentrations. And I was accepted to Wharton, and I was planning to go back to Philadelphia to go to business school. At the time, I was living in North Carolina, and I heard about this guy, Kevin Shulman, that was at Duke. And I figured, before I move my whole life and go back to Philadelphia, I'm going to call Kevin and find out who he is and what he's up to. And long story short, I had about an hour conversation with Kevin, and he convinced me to do my MBA and a clinical research fellowship at the Duke Clinical Research Institute. So I spent about 4 years really doing work with Kevin as my primary mentor around healthcare policy. And these 2 articles here are 2 of the first papers that I published as a clinical fellow. One was in the journal Science around looking at tuberculosis drug development, and the other one was a policy piece in the New England Journal around the ethics and science of globalization of clinical research. And I remember Kevin sitting down with me after I published these 2 papers, and he said, "Seth, I want to set expectations with you. You've just published your first 2 papers in the New England Journal of Science. Your career is probably going to go downhill from here." And so in some respects, maybe it did, but my experience at Duke was really, really great. I learned really about the importance of mentorship. I learned about the importance of taking on really big things and not being afraid to make waves and standing for what is right. Both of these papers were controversial at the time, but really catalyzed improvements in the way we conducted clinical trials and in the way we developed drugs for tuberculosis. And it also taught me about the really important value of having great teams. So the New England Journal, it was amazing what 2 emergency physicians, 3 cardiologists, a general internist, and a hepatologist could do when they put their minds together. And if you look at the small writing, you'll even see a guy named Bob Harrington there, who was a co-author on that publication and made tremendous contributions to the work that I did as a fellow and the training that I received at Duke. Next slide, please. So going to the next phase of my career, I made a decision to go over to the University of North Carolina healthcare system after my training at Duke. And I spent the first couple years at UNC really as a traditional health services researcher, and spent some time as a fellow with the Robert Wood Johnson Foundation. Also did a fellowship with the National Academy of Medicine, where I worked on a study around geographic variations in healthcare spending, which became a precursor to a lot of the work that Medicare was doing around alternative payment models. And about halfway through my tenure at UNC, I became really interested in not only about writing and analyzing about the organization of healthcare delivery, but really how do we drive changes that make healthcare more affordable and more sustainable. So this led to a role where I was the physician executive responsible for developing the population health infrastructure and moving more from fee-for-service to a value-based care healthcare system, and really driving at some of the core issues around affordability and sustainability of our healthcare system. And so I led that work for about 10 years, and we made a ton of progress as a healthcare system. And it really started to fundamentally change the way we were delivering care at UNC. After about 20 years in North Carolina, I really got the itch to do something different. And I had an opportunity to go to Salt Lake City, where I was the president of their medical group and also chief medical officer. And the work at Intermountain was really formative for my career because it reaffirmed my passion and interest in affordability and sustainability of our healthcare system. Intermountain is known for delivering the lowest per capita cost in the country for the care that they deliver. So I did a lot of work around driving care to home-based settings, transforming how physicians practiced in the offices, particularly around the model for primary care. And one of the things that I also appreciated about being at Intermountain as an integrated delivery network, where you had a health plan and a provider system working side by side, you could achieve tremendous synergy in really driving transformation in how care is delivered and creating much more alignment around payment and compensation models. And so that really was eye-opening for me. And then after a few cold and snowy winters in Intermountain, my wife also had a really incredible professional opportunity in the Bay Area. She's a physician as well. And there was this opportunity for me as the senior vice president and chief health officer at Blue Shield of California. And as a physician, I felt like I had a really unique opportunity to drive transformation within an established health plan, because I understand the provider world really well, and I understood the payer world. And the synergy between the two is really where you can achieve tremendous innovation in ways that are not possible when providers and payers aren't working together. And I also was always committed to affordability and making sure patients get the best possible care. And clearly, health plans and payers play a critical role in enabling provider organizations to do that in the most effective way. So I took this position at Blue Shield of California in March of last year. Let's go to the next slide. So I just wanted to hum a couple bars around Blue Shield of California. There was probably a short list of only very few health plans that I would have ever joined. And for me, it was all about mission and people. So the mission at Blue Shield of California is to create a healthcare system that is worthy of family, friends, and sustainably affordable. And so that affordability mission was critical for me. The organization also, has a great history of innovation and is really focused on the right things. So you can see the strategic pillars listed there: creating a personal, high-quality experience, focusing on patients, growing, serving more people across California, being financially responsible in terms of how we manage the business internally, and also being good stewards of healthcare premium dollars in terms of how we work with organizations, being a great place to do thoughtful work. The organization has been named one of the world's most ethical companies 7 different times, and was just named by Forbes magazine as one of the best places to work in healthcare. And really committed to standing for what's right. Big focus on diversity, equity, inclusion. Our board is 50% women. No pay gaps anywhere in the organization by race, gender, or ethnicity. And the Blue Shield Foundation is now the biggest funder of violence prevention programs in California, and just recently announced a $40 million contribution to address health inequities and racial justice and the values of how we work: human, honest, and courageous. So a lot of great things about Blue Shield of California that attracted me. Next slide. And just a little history about Blue Shield of California briefly, because not all health plans are created equal. And I think there's some important things to know about Blue Shield of California as an organization. It was actually established, it was the first health plan in California in 1939. It was established by the California Medical Association and was originally called the California Physicians Service Plan. So it was established by physicians for physicians. It was the first health plan to cover pre-existing conditions back in 1943. It offered coverage for people 65 and older about a decade before the Social Security Act created the Medicare program. And then a long history of innovation with delivery systems, particularly ACOs, driving improvements in quality and cost. And then expansion in terms of the focus areas, going from commercial to a lot of work in Medicare and Medicaid. And the organization now covers over 4.5 million members across California, has a network of 73,000 physicians, almost 400 hospitals, and is doing great work with a lot of organizations across the state. Next slide. And just a little bit about the overall healthcare strategy in terms of what attracted me also to the company. Really focused on driving healthcare to solutions that are more holistic, that address the full needs of the patient and member. We know that 60, 70, 80% of health outcomes is not by medical care, but it's environmental factors, social factors, genetics, environment, personalized care. A lot of this work parallels what you're doing as an organization around precision medicine. And then increasingly digitally enabling that care, high touch, high support, both in terms of how providers work and how members interface with providers and the healthcare system, and underlying that a data platform to use intelligent analytics, machine learning, AI neural networks, and using unique insights around whole person that really impact cost, quality, experience, equity, provider experience. So this is what we're doing as a company, and I think probably aligns really well with what you're up to as an organization as well. Next slide. And then lastly, before I roll into what I've been up to for the last year, this is just how my organization is organized at Blue Shield of California. 1,400 employees to execute against that mission, $300 million in administrative expenses, and responsible for really every dollar that goes out the door. We're a $24 billion company, $19 billion in medical expense to providers. How do we make the most effective use of those dollars so patients are getting the highest quality, most cost-effective care? And then the areas that roll up under me are all lines of business, including our governmental lines of business, Medi-Cal, Medicare. I oversee clinical quality, cost of healthcare. Medical care solutions is care management, utilization management. Mind-body medicine is focused on behavioral health and virtual care. And those are two of our biggest strategic investments as a company moving forward. And then also our pharmacy services, managing the pharmacy benefit, but also trying to drive a new prescription drug ecosystem that's more affordable, and forging partnerships with companies like Civica RX to really be able to lower the total cost of prescription drug care. So next slide. So I want to talk about what I thought I was walking into and all these great things and how we were positioned as a company, and what I actually walked into, and talk a little bit more about what the last year has been like as an executive at Blue Shield of California. So I signed my offer letter on March 9th of 2020. And I knew there was obviously a real issue with what was happening with COVID-19. And sure enough, 2 days later, the WHO declared a national pandemic. The entire Bay Area shut down. And on March 12th, I got a call from my boss at the time, Terry Gilliland, and he said, "Don't move to California. There's no place to move. We're shelter in place." And 7,000 employees went from working in the office to working from home, where they continue to work ever since. And so we were faced with tremendous challenges, and all of us, the greatest threat of our lifetime. And Blue Shield got really involved in supporting members, providers, and went headfirst into the COVID-19 response. And some people ask, why did we get so involved, not only in caring directly for the members we insure, but the mission and activity around the state? And I think the simplest answer is, we're not just an insurance company, we're a not-for-profit healthcare company that's mission-driven and that cares deeply about the overall health and well-being of Californians. And it's really just in our DNA. And I think we've taken action that's consistent with that throughout the pandemic. And I wanted to give you a flavor for the work that we've done, and also specifically talk about our vaccine work on the task force, because Kevin asked me to speak to that, and that's top of everyone's mind and a real focus area right now. Next slide, please. So just a couple key themes in terms of where we've been focusing our effort. One is on just rapid adoption of virtual care. It's been incredible to see how well it's been embraced by providers, by patients, and we're in a position where we've tried to provide maximum flexibility, both in terms of the types of telemedicine that's offered, and also waiving copays and co-shares during the pandemic to make it as easy as possible to use. And I would say, in addition to traditional telemedicine, we've been really also promoting what we call Wellvolution. And you can think of it as a Spotify for healthcare, where we have a lot of digital tools and therapeutics accessible in a web-based platform that focus on holistic needs of our members, and really a focus on preventing and reversing disease with science. So we've had over 5 million member interactions with that digital ecosystem. A couple ones that I like to highlight that have been particularly well received and effective is our work with Virta, which focuses on tools to manage and reverse diabetes. We've had 30% of our members be able to come off diabetes medicines altogether. 80% have lost weight. And also apps like Sandbello, which provides mental health resources and resources around emotional resilience, which has been particularly important in the pandemic. And I think one thing about really investing in the community is it provides lasting results. We, in the wake of the Camp Fire in Butte County in 2008, where a lot of areas were just razed to the ground, we helped the Paradise Medical Group practice rebuild, and it was largely a virtual practice to really be able to provide care. And so that infrastructure was in place and has actually paid dividends now in a COVID era. And so we're really able to support a lot of telemedicine activities at practices like the Paradise Medical Group. Next slide, please. Another theme has been around really trying to provide personal care and outreach. We had a lot of members that were obviously infected and got very sick or died from COVID-19, or a lot of our members that were really at risk. And we needed a way to be able to understand and risk stratify our members quickly in new ways that we had never done before because we had a new disease, and also be able to provide them the support and care that they needed. So we worked with Cohitativo, which is a Berkeley-based firm that works with healthcare systems around artificial intelligence, data science, machine learning, and developed an approach with Cohitativo that allowed us to get a multi-dimensional view of COVID-19 risk, which we could attribute at the individual or community or risk cohort levels using a number of different factors. And we were able to quickly risk stratify and also focus outreach programs to our highest risk members. And I think just looking even at the descriptive statistics of the work we did, which are captured in the tables here, we see significant disparities in access to care and testing rates. So we saw testing rates that were much lower in Medicare and Medi-Cal compared to commercial and ASO lines of business, and also hospitalization rates and deaths, unfortunately, that were much higher in our Medi-Cal patients. So a lot of the work was focused on these members and really doing the outreach. It was the types of things that families and people are struggling with around access to food, the ability to safely shelter in place when you have multi-generational families under one roof, economic security and financial security through job loss. And so really doing everything we can with our case management teams to support our members through a difficult time. And we're in the process of really analyzing the impact of that work, but qualitatively, it did really support a lot of our members in a time of crisis. Next slide. And just a couple other things I wanted to highlight around members. There was a lot of premium and cost share relief that I mentioned, really trying to offer as many mental health and virtual offerings as possible. With providers, we provided $200 million in direct financial assistance, either through advanced payments or loan guarantees, and also really tried to work to streamline authorizations, particularly during this big wave that we saw in Southern California, where did everything we could to really get out of the way of hospitals discharging patients where they needed to go, and also even work with hospitals and providers to be able to set up programs to eliminate authorizations for things like oxygen, and so that they could do home-based monitoring for patients that had COVID that maybe didn't need a hospitalization but required a closer level of care. So there's a lot of collaboration with our provider partners, really supporting our employees. As you know, it's created a lot of stress on everyone, and it's been very difficult working virtually, but have continued to do that. And I mentioned a lot of the work that we've done investing in the communities. One that I think is most exciting is an investment in youth mental health, which we made in high risk school children in San Diego and Alameda counties. And so training teachers and counselors to identify early warning signs of mental health, and then facilitate counseling. And during COVID, when we went remote, we shifted all of that work to being conducted over Zoom, and have had really good traction and results around supporting youth mental health. And there's a number of others listed there. So next slide. I want to talk about the work that we've been doing, particularly around COVID-19 testing and vaccine work. So this testing work was back in early in the pandemic, and Paul Markovich, who's our CEO, is pictured here, was one of the co-chairs of the testing task force. And the UC systems in Stanford were very involved in that effort and were really instrumental to the work that happened across the state. And at the beginning, there was very limited capacity to test, only around 2,000 per day. My understanding is there were large backlogs and critical shortages of equipment like reagents, swabs. And so this task force worked really hard to develop data systems and infrastructure to support testing. So the capacity went from 2,000 a day to over 100,000 a day by June, and has really been important in supporting Californians and supporting public health efforts through the duration of the pandemic. Most recently, as you know, we were asked to be involved in the work around the state vaccination network. So California is building a vaccination network to ensure more efficient, equitable delivery of vaccines, and to also have real-time transparency about where vaccines are so we can monitor inventory and track our performance. And the state entered into a no-cost contract with Blue Shield of California, where we're serving as the third-party administrator for the overall vaccination network. And the primary areas of responsibility for us have been building a network to meet the program requirements and to build capacity to be able to vaccinate efficiently, and also supporting efforts to ensure we can do so equitably. And I'm going to talk a little bit more about that work in the upcoming slides. So let's go to the next slide. So Kevin said, hey, you know, I think it would be really interesting just to understand how do vaccines flow from the federal government down to the state. And this is something that I actually had a hard time understanding until I was actually in it, because it's not simple, it's fairly complicated. So I just want to walk you through this. So the first step is obviously the federal government is responsible for contracting and negotiating the amount of vaccine supply. And so that's step one. And then the federal government makes allocations for the vaccine that it has received to the states. And it does it through two mechanisms. One is it can allocate vaccine directly to states through federal programs. And examples would be the long-term care facility program or some pharmacy programs, or it allocates the rest of the vaccines to the states, which is essentially a pro rata share based on the population of the state. So once the state knows what its allocation was, the way it was working when we started is then the state needs to determine allocations. And the way that they did it is they determined how much supply should go to certain providers. And what they did is they split up the multi-county entities, so the large systems like Stanford, UC, Kaiser, and they received 20% of the allocation. And then 80% of the allocation went to the local health jurisdictions. There are 61, 58 are in the counties, and there are 3 that are in the cities, Long Beach, Pasadena, and Berkeley. And then downstream, the local health jurisdictions were responsible for figuring out how many vaccines would go to which location or which provider. And those are the partner depots listed here. And then what happened is the manufacturers deliver vaccine directly to providers based on the guidance that we're giving them on these are the locations and these are how many vaccines we need to go to that location. I think, and then the providers administer the vaccine, and then there's reporting back to the state and the federal government around the overall utilization of the vaccines. I think one of the challenges was initially that MCE LHJ split. It's kind of hard to figure out sometimes what is the eligible population of an MCE or an LHJ, because you take a system like Kaiser, which is a closed system, versus a system like a UC system, which is a state big system, but it's an open system, and it's not super easy to define the denominator of patients who may be eligible for a vaccine. And so there's different methods or different allocation processes that were designed and tested to try and figure that out. I think you can get an appreciation for the complexity of the logistics. The other thing I would say is that when the vaccine hits the ground, all of the vaccines, whether it's Pfizer, Moderna, J&J, have completely different cold storage requirements, and they come in different sizes. So if you want to administer Pfizer, you can't cut the box in half. You got to be able to do 1,000 or more. And Moderna comes in much smaller sizes, around 100. So it's figuring out the mix, matching the mix to what a provider can accommodate. And more so lately, it's getting the Pfizer Moderna mix right, because you have to follow first doses with second doses. And then the other thing I would say, that site level distribution, there are different ways at the 58 or 61 health jurisdictions about how they distributed and track downstream. And I think some of them did a really good job, and it's not a knock at all on the work they did. It's just, how do you get a high level look at where vaccines are and how effective we are when you have all these different moving parts and different systems to make decisions and track where vaccines go. So that's kind of framing current state, maybe as of a couple weeks ago. Let's go to the next slide. I want to talk a little bit about vaccine supply, because we heard the president make a statement that he wants everyone eligible for a vaccine by May 1st. I would say right now we're in a supply constrained environment, and the unfortunate news is that for the next couple weeks, supply appears to be flat. And so the top line is first and second doses. And so you can see that line that crosses that vertical line. It says today, but this slide was created a couple days ago. You can see a little drop. What happened is we got some Janssen vaccine, but for the next 2 weeks, we probably won't get any. And over that time, the Moderna and Pfizer supply coming in is pretty flat. So March looks like kind of a zero-sum game. If you take vaccine from one part of the system, it's got to come from another, because the supply is pretty flat. It's at the end of March and into April where we expect a ramp in supply. Let's go to the next slide. Sometimes it's hard to understand. There's so many different manufacturers and moving parts. How does it all fit together? And are we going to have enough supply? And if so, when is it coming? And so this was an effort to sort of create a waterfall to help understand what vaccine we're getting and what we can expect. And it breaks it down into the Janssen vaccine. I mentioned we've gotten a bolus initially. We won't get some for a while, but they've committed to 100 million doses by the end of 2021. There's Novavax, which will probably come online. Earliest anticipated EUA date is in May, and there's some uncertainty there because it's contingent on the FDA accepting UK trial for the EUA, which I don't think there's a precedent for doing that. And then AstraZeneca, the early estimated timing for the EUA is in April. I think I just saw yesterday that they're going to be filing sometime soon. There have been some hiccups with AZ over in Europe, which could affect the timeline or even the ability to do an EUA. in the US. So that introduces a little uncertainty. But when you add up the columns, by the end of May, the projections that we did are that we should be able to have enough vaccine for 100% of adults to be vaccinated with that supply. It doesn't mean 100 million or 100% necessarily will be vaccinated, but we shouldn't be nearly as supply constrained by the end of May as we are right now. Let's go to the next slide. I want to talk about vaccination rate in California because there's a couple different numbers, and I think competing theories about how are we doing compared to other states and how are we doing compared to other countries. When you actually look at the USA and California based on total doses administered per 100 people, we're pretty consistent with other states. And if you look at a list of country ranking, we're actually doing fairly well. There are some that are doing incredibly well. So I'd highlight Israel and the UK, for example. I think there are a couple caveats to that because as I've been exposed to this work, there's always a balance between the efficiency of vaccination and what I would say is the effectiveness or maybe the equity of the vaccination. So Israel's been able to do it really quickly. They have some things working in their favor. They're a small country. They only have 4 HMO-like organizations. They have a universal health record. So they've been able to get it out pretty quickly. There are concerns in Israel about equity. It looks like it's going most quickly to the highest SES groups. UK has made a decision that they're going to prioritize the first dose and not the second dose. So what you have is a situation where a lot of people are getting first doses, but I spoke to someone the other day that got their first dose Pfizer and their second dose appointment is coming 12 weeks later, which is interesting because if you look at the clinical trials, first dose efficacy for Pfizer is really only in the 50%. So there's a question about, what is going to be the overall public health impact of that strategy. UK is also having problems with equity. There are a couple countries at the bottom which surprised me, like Japan. They've had a slow rollout. They've had challenges with some vaccines in the past and more hesitancy, I think, in that country than I had anticipated or expected. Some of the other European countries like France are also slow. They've had supply problems. They, in contrast to the UK, have stuck to their second dose recommendations, but are having capacity issues right now. So I think overall, as a country, there's a fair amount that we can be proud of. Next slide. This is a comparison of California by states, and what it does show is that for at least one dose, we're pretty comparable to other states. If you look at the percentages of doses delivered, we're struggling a bit. And this is where a lot of the work that the third-party administrator is involved with, some of the work around allocation and also supply chain. So we have an issue of, as I illustrated on that flow chart, hard to know where the vaccine is, which means it's hard to really track inventory effectively. And most recently, that led to some second dose shortage issues at large systems like Sutter and UC because of the inventory tracking issues. Right now, we have kind of a pull allocation, and for the providers in the TPA network, moving towards a push allocation, which really incorporates capacity and utilization at the site level with what are the overall goals, and really tries to make more efficient use of getting vaccine to the places that we need them. We need more predictability. So providers need 2 to 3 weeks out, knowing as close to possible how many vaccines they're going to get, because it's really hard to plan staffing and other efforts when you only have a 1 week look ahead, which is really how things have been working to date. So getting it closer to real time. Also, a part of what we're doing is trying to develop performance reporting so we can let providers understand how they're doing, particularly with regards to equity goals. and modify improvements as needed moving forward. Next slide. I think I'm going to skip this one, and if you can go to one more. I want to talk a little bit, just in the few remaining minutes, around the work that we're supporting the state in around allocation and moving to an equity framework for both allocation and administration. So if you look all across the country, and especially in California, we have large disparities in terms of who's getting COVID-19 and who's dying from COVID-19. And when we actually look at vaccine administration data, which this slide shows, we have fairly significant disparities in vaccination rates by race and ethnicity. So if you just take a look at the first two columns on the left, 39% of Californians are Latino, 19% of the vaccinations have gone to that population, and in Black, 6% Black, and 3% of the vaccinations have gone to that population. And so if you go to the next slide, one of the things the state asked us to work on as the TPA is developing recommendations on, are there ways we can look at a different framework for allocation, which incorporates more of a geographic or place-based approach. And the reason that's important, if you just apply age criteria, for example, you'll prevent 80% of the deaths in whites, but a much lower percentage of the deaths that are occurring in communities of color, because it's largely people who are younger, multi-generational households, have different risk profiles, and seek healthcare in different ways. So one of the things that the state is now employing is a Healthy Places Index, which actually measures the overall well-being in a zip code and is highly associated with mortality and also the demographic profile of who lives in that area, and includes a lot of things around social determinants of health. So it's got 70 plus factors that include economics, housing, access to care. And if you go to the next slide, what you actually see, this is on the right, a breakdown of quartiles, and quartile 1 are the least healthy communities. And you see that only about 9% of the people in California in these quartiles are fully vaccinated. And it's more than double and nearly triple the number that are getting vaccinated in these wealthier, high HPI quartile counties. So the current approach to allocation is that the initial vaccine is allocated based on the eligibility of the population. So the state is moving through different criteria. Right now it's age greater than 65. They had layered on agricultural and food workers, and now there's a new grouping of people with severe disabilities and severe medical comorbidities and disabilities that are opening up. So they look across the geographies and estimate how many people are eligible based on a proportional weighting of those criteria. And it was weighted 70% age, 30% based on the different types of employees, and so food and agriculture. And then there's an extra, they do that weighting to determine eligibility and apportion vaccines across the different HPI categories based on eligibility. And then there's a double weighting, so 80% of the vaccine is allocated, and then an additional 20% is allocated to the lowest quartile HPI regions. And there are some limitations to this approach. There are certain ethnicities that don't actually tend to aggregate in communities. They're separated, like Filipino and Hawaiian Pacific Islanders. So it misses some ethnic groups. And there are also some regions that don't have, that have low census tract areas that need to get vaccine, but may not fall into one of these quartiles because it's rolled up at the zip code. So I think one thing that's very important to remember about the allocation approach, and if you can fast forward one slide and go one slide more, this is the final thing I'll say about allocation is only sufficient to create a more equitable approach. Then you have to actually get people vaccinated in those communities. So there's a lot of work around the network side about building capacity and doing things like pop-up clinics for ag workers. A lot of homebound populations now, we're focusing on a network that's going to incorporate home health providers that can go in and not only vaccinate the person who's homebound, but the entire family that is living in that household. A lot of work that the TPA is doing in conjunction with the state around investing in community-based partnerships, because the only way to get people vaccinated in these lower income communities and to meet the equity goals is going to be really to partner heavily with community partners, and then a large public education campaign as well. And so one slide, I just want to close up and say, in terms of thoughts about what's coming, I think we're obviously going to have more vaccines in April, which is going to help. The May 1st goal that President Biden said is aspirational, and I think a lot needs to happen for us to be able to operationalize that so we can get as many Californians vaccinated. I think the goal still stands as getting us to herd immunity 80% by July 4th, and doing it in the most efficient way possible to save as many lives. And I feel confident in the ability to do that. Still need to do a lot of work around these equity plans and making sure the right communities are getting the support and getting vaccinated. Then I would say we have to also step back after this pandemic is over and learn from our experience, both as a state and evaluating the effectiveness of how the public-private partnerships have worked, so we can be more nimble and responsive for the next emergency. So I'm going to stop there. I realize I went over a couple minutes, and hopefully there's some time for some Q&A too.
Absolutely, Dr. Glickman. Thank you so much for sharing everything from personal to operations at Blue Shield and now vaccination. I know that a lot of the vaccination responsibilities weren't necessarily something that you may have, I don't know if you've foreseen this when we invited you to come speak. So definitely things adapted in the last few months. So thanks for staying with us and presenting today. And if you're still okay, perhaps we go 5 minutes over and try to get to a few questions here.
Yeah, absolutely.
Get right into it. So various questions about, no surprise, vaccinations, some of the important things right now. Qualified patients are having trouble scheduling vaccinations on My Turn. Many don't see Santa Clara, San Mateo County mass vaccination sites offered. Is there a separate scheduling system for the county sites? I know a lot of this is still developing.
Yeah, more and more are using My Turn. It's still some are on My Turn, and there will be more moving forward. So My Turn is still the preferred scheduling system, but county by county there's variation. So I think it's still valuable to work through the county health departments and local providers whenever possible. I think Kern, and there's one other county that just went live yesterday, and so I think we'll see more and more on My Turn going forward over the next month.
Okay, great, thank you. Next question, Andrew Newman asks, the authorization process for non-covered medicines or scans is still completely dysfunctional, waste time. This should all be changed to an online process. Any thoughts on that? Of course, we'd love to decrease paperwork. Is there any thoughts you have on improving that process?
Non-covered medicines, and what was the other thing?
And scans, like imaging.
So I would say that I am very committed to working to make the authorization process work more effectively for providers and patients and members. I've had some preliminary conversations with some of your faculty in the Department of Orthopedics around spine surgery authorization, and we were able to, I think, implement some solutions that help. So might be best to reach out directly with me, and we'd be very happy to have a conversation about what the pain points are and how we can make that work better.
Thanks a lot. Linda Barman asks, talking about our close community here, East Palo Alto, 1 out of 6 residents, including children, had had COVID, so it's been hit really hard. Is there any thing you can comment on in prioritizing different communities as far as vaccination?
Yeah, so I mean, generally, you saw the allocation. We're trying to send more vaccine to the places it's needed most, and then each individual county has developed its own equity goal for describing how they're going to operationalize vaccination to ensure that the shots are getting into the right arms, including reserving 40% of the appointment slots for the intended population. So it's really a lot of the work, I would say, is very locally dependent and is leaning heavily on our partnerships with community-based organizations to help both with issues around vaccine hesitancy and then the logistics of actually getting people vaccinated.
Gotcha. Manali asks, and thanks so much for going through a lot of questions fast to get to as many as possible. A general question asking in the sense of course, Blue Shield is doing a lot of public good by being a major driver of vaccinations. Is there any other drivers behind that we'd want to know about aside from that? Any incentives for the process you're doing with vaccinations?
No, I think it's really about supporting the state and supporting Californians, and you know, it's not a forever thing. I think we'll be on the other side of this, and so I think especially around the areas where we can bring expertise and speed around areas like the network. So the network that we've developed supplements the existing network, but adds a capacity for doing an additional 2.6 million vaccinations a week and gets us to a place where it's 4 million additional weeks of getting to us a place where we can vaccinate quickly and efficiently, and includes, I think, all the multi-county entities, almost all the FQHCs, community health centers, a lot of pharmacies. So that's really kind of primarily where we're focusing on and what we're here to do.
Okay, great. As we're hitting 9:05, perhaps we'll entertain Julie's question here before we close. It's a good question. Julie Wissink asks, there have been reports of vaccine access codes intended for high-risk communities being used inappropriately by people at low risk to get vaccines. Is there a plan to use one-time code or another plan to help high-risk communities?
Yeah, there is a plan around that, because we think it's really important that if we're going to the trouble of sending vaccine to a certain area and working really closely with providers and people who live in those areas, they need to be the ones who are the recipients of the vaccine. So there's some functionality in my turn that is not fully operational, but is being developed, that we can create personalized appointment codes, and also for groups of individuals. Some of the regional centers or independent living facilities can have a group code and do scheduling on behalf of their clients, because we're trying to really drive equity and avoid situations where we have people coming from other areas to get vaccinated who are not the intended recipients of those vaccines. I think that's really, really important.
Dr. Glickman, thank you so much for being with us today. I want to end with, we have a lot of questions here that we won't get to. I can certainly send them to you if you'd like to answer any. We can send them out via email, your answers. Manali asked a few questions, just put in here. Thank you for taking this on. It does indeed, it's a village effort, so thank you. And I'll add my thanks to that as well as to being with us this morning. Thank you to all our panelists and for all the attendees for joining as well. And we hope everybody has a great day and great week.
Thank you very much.
Thanks a lot. Bye-bye.
Bye.